is our product. This is made by us and made on our demands and requirements. We started in, we actually started in 2005 with the first pipeline case, which was kind of just coming from the shelf. It was a kind of a humanitarian device, which the device used, which worked very well. And using pipeline in September 2009, and we mostly finished it in April 2012, having treated 189 patients. And amongst those were 146 sacral aneurysms. I focus a little on the sacral aneurysm thing. With pipeline, at this time, we tried not to use pipeline in acute ruptured aneurysm. We used pipeline in aneurysm remnants after coiling and clipping, and we tried to avoid treating large aneurysms, large and giant aneurysms with flow diversion, since we didn't trust the function, and we didn't use pipeline or any other flow diverter as far as aneurysms. The aneurysms treated with pipeline at this time were mostly relatively small aneurysms. The medication was pretty much the same, what is used everywhere, and we observed that we needed a couple of pipelines to really get a good flow diverting result. So in average, we used a little more than 3 pipelines per device. We had the goal was to seal the aneurysm with the implant, and had incomplete sealing of the neck in 5 cases, which was mainly related to the fact that we couldn't properly place the device. We had displacement in the sac of a large fusiform aneurysm in 1 case, and we used pre-dilatation and post-dilatation deliberately. The adverse events, and this was exactly the trigger point to come up with a new development, was the observation of hemorrhages after flow diverting treatment, 1 subarachnoid hemorrhage, 3 intracranial parenchymal hemorrhage, and 4 thromboembolic parent vessel occlusions after using pipeline. At this point, we already had response testing. We used in the very beginning Verify Now and shifted for a variety of reasons to multiplate, but these thromboembolic vessel occlusions were not related to non-responder status. They were related to mainly to incompliance of the patients. Follow-up results for both the lesions in total treated with pipeline and the sacral aneurysm, they are pretty much similar. So you can expect the cure of the patient after 3 months. This is the first block. After 3 months in 50%, and this increases complete occlusion of the lesion to 75% after a little more than a year, and you have remaining perfusion, but the real failure rate is relatively low after a year. With this development of P64, since then we treated 173 sacral aneurysms. We started under certain circumstances to treat ruptured aneurysms. We mostly treat, of course, untreated lesions. We try to avoid, but it's not always possible, to treat lesions that have already a stent or a flow diverter inside. And of course, flow diversion is a good indication for coiled aneurysms and for remnants after surgery. Just a very simple example of ruptured aneurysm. This is the CT scan, the PCOM aneurysm, which was coiled. The patient already had a ventricular drainage in place. She got quite fragile or sensitive vessel, so any manipulation caused significant vasospasm. This is the result immediately after 20th of July, 3 days later, and in November follow-up. Perfect clinical outcome, perfect anatomic result. So I think in non-bifurcation situations, if we see a significant remnant flow after coil occlusion, we deliberately use flow diversion today, and we are quite pleased with the results. Early recurrence after coil occlusion is another example. Subarachnoid hemorrhage, parathalamic aneurysm. This aneurysm was coiled, as you see here. There's a neck remnant, but we thought, okay, we may do it later. The patient was suspected to have vasospasm, came back for an angiogram a few days later, had this recurrence, which was again treated with a flow diverter. This is immediately after. This is again immediately after, and this is a follow-up with a few months later, perfect reconstruction of the vessel. So Again, early recurrence, fortunately, it's infrequent, but if it occurs, can be a very good indication for using a flow diverter in addition to coiling. This was an aneurysm with this rupture, ACOM aneurysm. I wasn't there, and the neurosurgeons thought it would be a good idea to clip this aneurysm. However, the professor was away, and the result is what you see here. The aneurysm is partially clipped, and the right A2 is gone. Certainly, this aneurysm is not really covered and sealed. It didn't provide enough neck to put a coil inside, and we used an Enterprise in this shallow curve to straighten the vessel, put a flow diverter into the Enterprise. This is November, and this is 3 months later, with perfect reconstruction of the artery. The patient fortunately had perfect collaterals from the MCA to his right ACA and survived without any deficit against all expectations. We mostly use flow diverters in the anterior circulation and are slightly reluctant to use it in the posterior circulation, and you will see the reasons why in a few seconds. The majority of procedures today is done with a single device, and the experience is that a single device, if you use a higher density device like P64, is simply enough. We had 7 failed attempts. These failed attempts are related to the device history. We had friction issues in distal locations, and of course, all these devices need large microcatheters, so you may observe vasospasm if you try to bring a 20,000 ID microcatheter in a tiny vessel. We had 3 permanent device malpositions. All these device malpositions happened in a way that the device was deployed in the proper position and it foreshortened after deployment. The pre-dilatation and post-dilatation is still used whenever necessary. This is an example for a failed attempt. This is an ACOM aneurysm, and it's difficult to tell why. I personally tried 2 times to coil this aneurysm, and I always had difficulties. I think mainly because the lady had a terrible tendency to vasospasm, and it was always not nice, no stable position of the catheter. It looks odd, I admit it. I had difficulties to coil it and try to put a flow diverter. Again, the same situation, the catheter is inside, but the artery is immediately occluded despite giving nitroglycerin in the ICA. So we withdraw the microcatheter, no damage, it's simple this is simple vasospasm. We put an Enterprise, waited for a couple of weeks, and put in flow diverter inside the Enterprise, and the aneurysm is gone. This follow-up right ICA, left ICA injection, no more ACOM aneurysm. She had plenty of other aneurysms, so if you see material in the background, this is related to other aneurysms treated. Device malposition is, it happens, as I said, encountered, it was always related to a secondary migration after deployment of the device. This PCOM aneurysm, the flow diverter is in the proper place. The flow diverter is covering the aneurysm. This is after deployment, the device is deployed. And if you look carefully, you see that the device foreshortened. It is no longer covering the aneurysm. It's no big deal. I mean, you come back and put another one, but that's certainly not what we originally want. Pre-dilatation of the landing zone, huge cavernous aneurysm with cranial nerve palsy. The landing zone is obviously stenotic here. It's no big deal to coil the aneurysm, to come with a balloon, dilate this landing zone, and put a flow diverter, and have a good result. So if you go to the results, these are all saccular aneurysms. After 3 months, we see, again, 50%, a little more than 50% complete occlusion with insignificant remnants in 23% and significant remnants in about 1/4 of the patients. And after a year, the numbers increased to 75% complete occlusion of these saccular aneurysm, minor remnant in 15, and significant remnants in 11. The significant remnants are almost always related to unfortunate anatomic situations. You won't see significant remnants in the regular sidewall aneurysm, but you won't see, you will see significant remnants if an artery is originating from the covered aneurysm. The artery coming off this aneurysm sac will undermine the hemodynamic effect, and of course you see significant remnants in bifurcation aneurysms. The results are even better if you look at aneurysms that are secular and that have no previous treatment, no other flow diverter, and no others stent inside. It increases the complete occlusion rate, and in this subgroup, there's only a 6% rate of significant remnant of the aneurysm after a year. This was a lady with an immediate, if we come to the timing of aneurysm occlusion, this was a lady with a clipped ACOM aneurysm. The clip is below, and this is the second aneurysm pointing upward. She didn't want to have another surgery, and this is the aneurysm here. You see there's these two connections between the anterior cerebral arteries, and this is the aneurysm. It's not strictly an ACOM aneurysm, it's strictly an A2 aneurysm. Catheter, flow diverter, prior to deployment, flow diverter deployed, and I don't have the injection from the left side, but the aneurysm was instantaneously no more filling with stagnation in the aneurysm. This is infrequent. The more typical situation of this periophthalmic aneurysm treated in August last year. The flow diverter is in place, and this is the immediate result. These are MRs in August. The aneurysm is shrinking. This is October, and this is a follow-up in November. The aneurysm is gone, the ophthalmic artery is paid. This is fortunately in properly selected sidewall aneurysms, the usual sequence of events. This is what you can expect for those aneurysms which have no complicating aspects like vessel coming from the aneurysm or bifurcation situations or things like that. Delayed obliteration in this case, I think, was mainly related to an overreaction to aspirin and Plavix. The patient with regular dosage 100 aspirin, 75 Plavix, was completely suppressed in his thrombolytic function. This is November 2013. The flow diverter is inserted. The aneurysm is, of course, still there. There's stagnation of flow in the aneurysm. This is November 13. This is February 2014. This was the point when we thought, okay, we go down with the dosage. We cut the aspirin to 50 milligram and gave half a tablet of Plavix instead of a full 75 milligram. This is February. This is June. And this is August the same year, now under aspirin, no more Plavix. So one of the factors that may be related to delayed obliteration of aneurysms after flow diversion is certainly an overreaction of the patient to the effect of aspirin and or Plavix. Adverse events: we had no subarachnoid hemorrhage from the target aneurysm. We had no intracerebral hemorrhage in the dependent brain area, and I personally think the reason why this is the case is relatively simple. A few months ago, I saw a paper published in Neurosurgery written by Krings from Toronto. He showed endoscopic images, including images from in vitro and in vivo deployment of pipeline, and I think it's the same is true for most other devices. And what you see in these endoscopic images is you unavoidably have a shower of air bubbles if you deploy the device, even if it is flushed, and if you do it properly, you can't avoid a shower of air bubbles deployed. This is different with the P64. The P64 can be, without deploying it, can be fully opened. You can wash it underwater. You can remove all the air. You pull it back in the catheter, and I think this is a very efficient method to avoid air bubbles and air bubble related microischemia, which may be a factor for the creation of parenchymal hemorrhages. We saw 4 side branch occlusions. Two of them were symptomatic. We had 9 transient deficits, mostly embolic. Two patients died, one from pneumonia. The patient with pneumonia had a large cavernous aneurysm, and we told him that he should reduce the amount of steroids, but he continued with high dosage of steroids. One patient committed suicide. Intimal hyperplasia is not really infrequent, but it's infrequently symptomatic. Intimal hyperplasia example, parathalamic aneurysm, coiled and flow diverted, and there's a cross-flow from a spontaneous cross-flow which is related to this intimal hyperplasia inside the flow diverter, which can easily be removed just by single balloon dilatation, and the aneurysm is gone. This is the most severe case of intimal hyperplasia we observed, a superior cerebellar artery aneurysm patient with several aneurysms, and this was the flow diversion immediate result, flow diverter in the basal artery running to the P1 segment. The patient was kind of difficult. He is a severe smoker, and he was quite incompliant in taking his tablets, and this unfortunately we understood after we had treated him. And this was done in June 2012. On November the same year, with the already obvious shrinking of the aneurysm and intimal hyperplasia. At this time, he came back, had survived a pontine ischemia with a surprisingly relatively mild hemiparesis. He was walking, it was just spastic, but yeah, no doubt, severe stroke. This was the result. He had several other aneurysms, and now he decided that he wants to go for surgery. The guy who operated on him clipped the aneurysm. This is the clip for an ACOM aneurysm. This is a clip for the MC aneurysm, and this is the clip supposed to be on the superior cerebellar artery aneurysm. The clip is certainly far away from the aneurysm, but the aneurysm is gone anyway. So malposition with P64, which can be withdrawn and redeployed, can be avoided prior to detachment. If the implant shrinks after detachment, you can't avoid it, but it's fortunately infrequent, and it's mostly rising of the device. One device is mostly sufficient. We fortunately had not encountered a parenchymal hemorrhage or aneurysm hemorrhage after flow diversion with this device for a variety of reasons. The symptomatic intimal hyperplasia is fortunately infrequent. We see a high rate of aneurysm occlusion during follow-up, but I think that's not the main point. The main point is the avoidance of parenchymal hemorrhages, and we are more and more reluctant to use the device in the posterior circulation, given the fact that that's the spot where we see issues with side branch occlusions. Thank you very much.
Any question? Thank you, doctor.
Thank you, Hans. One question. You have 23 intimal hyperplasia, and the question is how many days the hyperplasia is? Initial hyperplasia, or is 1 week hyperplasia, 1 month hyperplasia? You're finishing after procedure with balloon remodeling after placenta stent.
Yeah. You see a relation of intimal hyperplasia, interestingly, with smoking. The majority of these patients are severe smokers, so we tell the patients that if they are smokers, they should quit, or if they're a smoker and they want to continue, I think anything else but flow diversion could be a better choice than going for flow diverter. The case we had seen with symptomatic intimal hyperplasia, she had severe headache, which was probably related to compromised flow, was a combination of both smoking and taking her tablets every now and then.
The second is you are the difference with the different device, different mode of hyperplasia, because in my experience, in our experience with the some flow diverter, you are more possibility the hyperplasia with another flow diverter. I don't know the name, but I think it's different, the Silk or Papeline or. Well,
I can't compare with Silk. I have very little experience with Silk, and not with other flow diverters. I would say we observe the same frequency of intermittent hyperplasia with pipeline. That's my only comparison. It's no big difference.
And why do we never see people from the P64 company in France and in my department?
Sorry?
Why do we never see rep or people from the company producing this stent, which is your company, basically, in France and in my department?
We can easily ask Christophe Letac why he failed to visit you.
So we have to ask the company to come. So it's a new world.
No.
Well, usually the company come and say, we have this kind of material, and why don't we use it? And here it's the opposite.
No.
So you're like Apple. You produce the market, and people, run behind the market.
Yeah, I mean, I don't know the answer. What I know for sure is that I think with Christophe, you treated an aneurysm with P. conus, and I can't tell you why he did.
But that's it.
So it is a...
And the P64, I have never used the P64 in my life.
That's unfortunate.
Yes, absolutely.
Yeah, I mean, it's easy. I mean, I stand here. You complain, I go to Christophe.
I don't complain. It's a question,
I don't know the answer.
Yeah.
Yeah. So let's ask Christophe Letac why he's doing why he didn't show up with you.
Okay.
Dr. Demetrius.
Demetrius está aquí. ¿Está?
Okay. Dr. Christian Tascher, Surpass Flow Diverters, is here.
Sí. Christian.
Yes. Christian is not here. Christian Tascher. Okay. Dr. Kim Nelson. No, it's not here.
Está ahí. ¿Cómo se llama? ¿Quién es ese?
No. Kim Nelson is here. Okay.
Es Demetrius no está aquí.
No, Demetrius.
El de Pipe.
Muy común con brasileños.
Do you think it's better to put the long stem flow diverter or the short stem? To put one or two or more longer with a difficult navigation? Well, you start.
It's not a simple answer. I think that the length of the flow diverter depends on the difficulty of the positioning. If you have a longer one, you have more flexibility. Fortunately, we have different variety of stents. So we clearly know that some of them navigates better than the other. So when the anatomy is difficult, you better use the stent that navigate the best. But basically, the length is definitely depending on, the facility to deliver the stent at the right position. From a theoretical point of view, the less coverage of unnecessary vessel is the best. But, practically, you increase a little bit the length when it's difficult. It's not a simple answer. You have theory and practice.
Dr. Professor Kim Nelson will use of pipeline flow diverters.
Hello. Thank you, Luis, for inviting me. It's very kind.
Welcome to Madrid.
Can I presume that I can take up the time of everyone else? Okay. So Luis asked me to come and talk about the rational use of flow diversion, and that's a little presumptuous. I guess we know one another, and I'm not sure that we would describe one another as rational, but at least emotional to some degree. So yeah, in thinking about this, I think it's true not just of flow diversion devices, and I don't particularly like that term, but it's true of all of the therapeutic terms. Like Professor Murray had previously illuminated, whatever we're using, whatever tool we're using, there's certain guiding principles that need to kind of come into play in terms of how we decide to approach a patient and how we ultimately select devices for treating aneurysms. And these basically can be distilled down into a certain set of principles. You need to have a clear vision of what is the goal of your therapy. You know, and I think overall, we can say that we want to have an uneventful circulatory exclusion of the aneurysm. That would be ideal. And so that's the goal. Whether or not you want to talk about the perfect result, I think in essence, we do want the perfect result. Just like when a surgeon goes to clip an aneurysm, he's not going to partially clip. Sometimes he has to accept partial clipping of the aneurysm. But we go for the true anatomic reconstruction of the vessel. And I think that's kind of critical as a guiding principle, but not as necessarily the controlling principle. We need to have insight into the disease state and also the particular anatomic peculiarities that come with each case. Cases are unique, they're distinct, and they demand different tools, much like a few of the cases that he showed earlier. Basically could only be addressed in one of certain ways. We need to have insight into the features, the properties of the tools that we're using, as well as their limitations. What can you expect of a tool? A tool is just a tool. It's the operator that's using that tool. And the operator has a responsibility to be intimately familiar with the tool that he's using, not just accepting what a company representative tells him about the tool or what colleagues might say. You also need to have some insight, some understanding of the instrument that you're using, so that you can begin to sort of understand where it might be useful. And then lastly, you really need to have an honest assessment, an honest appreciation of the risk-benefit ratio. There's some things that we do that have very high risk associated with it, but the benefit to a patient that has a very morbid disease can be profound. So we have a general understanding of coiling. We've been doing that now actually, I started my fellowship when the GDC was released at NYU with Alex and the team there. So I feel like my whole career has been sort of punctuated by coiling. And so we have a simple understanding. We go into an aneurysm, we access the aneurysm, we deploy coils, the coils alter the flow and create a sort of thrombogenic environment within the sac of the aneurysm. And ideally, that thrombus coil complex organizes and allows a sort of intimal healing at the base of the aneurysm, ideally. And that's how we think about it. But we know that it doesn't always work, and this is just not picking particularly on Matrix, but this is a very nice data set that shows the results with bare metal coils and Matrix coated coils. And you can see that there's a significant incomplete occlusion in these aneurysms of all sizes, more prevalent in the larger sizes, obviously. And so do we really understand what's going on here? We've been coiling for now over 20 years, but do we really have insight? This was a case sent to us to Pipeline, had been coiled twice, and actually looking at the initial coiling, coiled quite completely by a very competent operator. Nevertheless, after 2 sets of coilings, there's a recurrence, and the recurrence has driven the aneurysm up into the optic chiasm. Now the patient basically is only able to see in the right half of the visual field, otherwise blind. So recurrences do have consequences. We can't talk about the neck remnant as if it's no problem. It's unpredictable whether it will be a problem, and that becomes the concern. So we talk about a number of things: aneurysm size, neck size, intraaneurysmal thrombus, coil packing density, the completeness of aneurysm packing. But we really don't have a truly scientific understanding of everything that's in operation here. So let's turn to flow diversion devices, because that's what I'm supposed to be addressing here. And there are a couple of principles that we need to first understand. Ideally, we're dealing with two situations. We have an aneurysm, and we want to close flow into that. We want that to go away. But the device is likely to be placed across a branch vessel that may be critical. And so we need to somehow preserve flow in that vessel, and we need to close the flow into the aneurysm. And so going back over a decade, there was quite a bit of animal work that was done to try to define a porosity where we could more or less guarantee that the aneurysm would be closed. So if you have a device with a specific porosity below which aneurysms will close and above which the aneurysm stays open, you can define that as the critical threshold porosity for closing an aneurysm. Then you can do another set of experiments and look at branch vessel patency. And you can define another porosity above which the branch vessel will stay open, but below which the branch vessel closes. And what we call this difference, this zone, is our effective treatment porosity. So there is a range, there's a safety range where we can effect what we want to therapeutically, but not cause harm. So just in a cartoon sense, to go over this global understanding of how these devices might work, you have an aneurysm with some sort of chaotic vortical flow going into it. You place the device ideally across the neck of the aneurysm. Because you've changed the exchange between the parent artery and the aneurysm sac, there's slowed flow in the aneurysm. The circulation, intraaneurysmal circulation changes, and by Virchow's triad, you end up with a thrombosis. The thrombosis can grow. Ultimately, if the mesh is sufficient enough, if there's enough of a density of mesh across the aneurysm, next you get an intimal overgrowth, and that leads to aneurysm occlusion. And we know this from doing a lot of animal work in rabbits and rabbit elastase models. We know that. We know also that if there's a branch vessel here, within certain limitations, you can preserve the flow, the laminar flow within the branch vessel somehow inhibits the overgrowth of that vessel by an intuba. Now, do we totally understand that biologically? No. And it's many times closing in a delayed fashion. But this is something that we sort of empirically discovered later. In the initial set of experiments, though, we became satisfied that tools of this porosity could be used safely in human beings, and that ultimately led to their initial trials. So we can distill down essentially these mechanisms of action into hemodynamic functions, and I think much more importantly, bioinductive. So the hemodynamic comes about as just changing the exchange between the parent artery and the vessel. It leads to the thrombosis of the aneurysm, but I have to caution you, that does not mean that the aneurysm is occluded, that it's cured. What is required for cure is that you have a remodeling of the vessel, you have intimal overgrowth of the aneurysm neck, and that you have a normalization of the vascular segment. And this is an example of that. This was one of the cases that we treated in PUFFs, a very complex cavernous aneurysm, a woman coming in with a complete ophthalmoplegia. It's not just the aneurysm. The aneurysm is partially thrombosed, which makes it worse. But look at the caliber of the vessel. The vessel is diseased. The vessel is compressed. Not just that you have the mass effect of the aneurysm, not just that you have all of the neurologic deficit, but the vessel is also diseased. This is 6 months after the pipeline construct has been put in place. It's not just that the aneurysm is occluded, that the mass effect is gone, but look at the caliber of the vessel. The vessel is normal. And so this is what really started to excite me, is that you put a device in and it matures with the biology of the tissue. And so you change the vessel, you remodel the vessel, and that's ideally. Does it happen all the time? No, because we are imperfect and we're not always perfectly treating these cases. But this is ultimately what we want. Now, the problem is that the literature has become polluted by a lot of observations. And I'm not causing. These are actually a publication coming out by some very good friends of mine. You don't want to make it personal, but let's be honest about the observations. What are the conclusions in this limited single study? Very similar to Intrepid, actually. That the treatment with a single pipeline embolization device provides similar occlusion rates with less complications and better overall outcomes. Well, there's a problem. What they're doing is they're comparing their single device treatments with their multi-device treatments. Even in their own abstract, there's a flaw in the science here. Let's look at this. There's no statistically significant difference between the two groups with respect to baseline characteristics, except for age and size of aneurysm. So we're treating our large aneurysms with the multi-stent. Of course, those are more complicated. You're going to have more complications. And this is what's really corrupt about the whole situation, that the editorial boards are not even doing the job of assessing the science that's going on. And so you're confused by a lot of data. Here's my venture into this. This was a large ophthalmic segment aneurysm that came to our attention. We had a very nice deployment with a single device. You have the delayed stagnation within the aneurysm, and it looks quite good. Very promising. The woman comes back at 6-month follow-up angio, and you see basically angiographically it looks like great result. There's only one problem. The patient has gone nearly blind. There's light perception only now. So what's happened? Look at the MR. You have a thrombosed aneurysm that has grown 50% in size. It's now pushing the chiasm and going over to the other optic nerve. So this is the problem. A thrombosed aneurysm is not a cured aneurysm. You can still be clinically active. And this is the dilemma. So while you have exchange across that aneurysm neck, across the endoluminal construct, the clot behaves like a fluid. It can continue to grow. And so it's not a cured aneurysm. So let's look at some of the properties of braided stents. And we published this a while back in AJNR just so that everyone would have an understanding of this. When you take a device and you oversize a device, or you take, in this particular case, it's a 4.25 millimeter diameter stent, and you deploy it in a range of diameters, you can see that essentially the cell structure changes considerably depending on the ratio of the diameter of the device to the diameter of the vessel. And so at supranominal, you can actually get quite a compression of the cell structure and a density. At nominal, you have a certain ratio. And then at subnominal, essentially you are approaching much lower degrees of coverage, much higher porosities. And then again, when it's vastly oversized, you come back again to a different orientation of the cell structure such that the porosity increases again. And that can be described quite nicely. My 15-year-old did this for me, looking at the parabolic relationship of the cell structure to the ratio of diameters between the device and the aneurysm. So it's very important to think about what is the size of the device that you're selecting and what is the situation you're putting it in. You might want to exploit some of this in covering perforators that are adjacent to the aneurysm, and you have an oversized device. It might be that you undercover the perforators, and that might be desirable. You have to be somewhat cautious, though, because if it's a complex necked aneurysm that's circumferentially involving the vessel, you can get into this derangement, and others have also shown this, where you have, in this particular case, a 5 millimeter device that's over-deployed within a 3 millimeter vessel. It comes out, so that would be distal to the aneurysm. You come into this complex neck aneurysm, and you deploy the device. Now, let's say we're trying to deploy it under load, and so you're loading the catheter, and you're trying to increase the coverage over the neck. The problem is, this zone here, this near the exit of the aneurysm, cannot be compressed because it's constrained by the fact that the device is constrained here. Furthermore, you get a deformation of the device within the exiting vessel such that you create this marginal lip effect. And that can lead to improper seating of the device and reverse endoleak ultimately as you go into the evolution of the device within the aneurysm. So how can we do this differently? Furthermore, let's think about it hemodynamically. If flow is going in this direction, you have an area of lower porosity at the inflow zone of your aneurysm. And then back here at the exit, at the outflow zone, you've increased porosity. So now there's a mismatch between inflow property, inflow resistance, and outflow resistance that may not be a good thing. So how can we do this? And this is where it takes a little bit of the art of the medicine that we're trying to do. So let's match the sizes a little better and try to get a different kind of construct. So we can take a device that's matched to the exit vessel, to the distal vessel. We can lay that across the aneurysm. And then we can come with something that's more appropriately sized for the proximal part of the vessel. And this is a common situation. You're constantly seeing these in parophthalmic aneurysms where the supraclinoid segment is narrow and then the cavernous segment is a millimeter larger in size. And you can create a construct so that you have single coverage proximal and distal and multi-coverage over the neck of the aneurysm. And you can shift your transition zone back here into the normal vessel where it's not as problematic. The other thing you can get with different sized overlap stents is you can get a very complex structure to your overlapping devices to ensure that you've chopped up the porosity to a degree that best facilitates entomal overgrowth down the road. And then this is really what you hope for. This was a device in PUFFs also where we used 3 devices over this ophthalmic segment aneurysm. And you can see that by the 6-month angio, and this is what I caution you, these cases need to be judged not just by their angiographic outcome, but by their cross-sectional outcome. Because what you're really looking for is you're looking for that aneurysm to go away, to resorb. Now, obviously, there's much more complexity. You have curvatures and the differences in the porosities related to curvatures, and it's even more complex than just bending a thing and describing it like I have drawn in the illustration here, because the stent can be constrained in different segments. In addition, in overlaps, you can have a periodicity where the devices are not perfect, that the devices, even being mismatched and overlapped, they create zones, periodic zones of undercoverage. And that has clinical manifestations, like in this case, where we have 3 stents across this large paraclinoid segment aneurysm. And you see at 12-month follow-up, there's still a little jet coming right through one of these areas here. So the summary of the clinical studies, we know from PITA and PUFFs that the thing is that the device is effective within a certain acceptable level of hazard. But it's important to understand that these trials were done with targeting specific kinds of aneurysms. In Europe, there was a much more liberal regulatory approval of the device. In the US, it's much more constrained. Nevertheless, we're able to use the devices off-label. Now, subsequently, there have been large meta-analysis and the Intrepid registry recently, which has more or less confirmed the observations in these 2 trials. And supported the use of these. But where are we going beyond the use of these devices in very large aneurysms? And that's where we need to think about the rational use of these tools. We knew actually this is a case going all the way back to PITA, with a large ophthalmic segment aneurysm with a small bystander aneurysm. The bystander aneurysm actually would be, I think, difficult to address with coiling. But with a device like this, you can come and address both of the aneurysms. So there's that advantage. Here's another small ophthalmic segment aneurysm, but because of its kind of unusual neck configuration, I believe that it would be difficult to securely coil, and you'd have a remnant, and it would come back, even with balloon remodeling, or with the low porosity stents, the high porosity stents. You'd still have, I think, some difficulty securing that aneurysm. But with a device like a flow diverter, it's very, very simple. Okay, this was a case at NYU, a patient having a transsphenoidal for a large pituitary aneurysm. They got into the carotid artery, and this is what you see here, these pseudoaneurysms. In the past, there were some dicey things that we would have to do. We would see if we could actually take the vessel down. That was the primary therapy. And if it couldn't be done, then we might try to overlap a few neuriforms or close the vessel, bypass the artery. It was always a dilemma. With these tools, we've actually had quite a few cases. I know Demetrius was going to talk about blister aneurysms because I think the blister aneurysm or these types of pseudoaneurysms are very nicely addressed by this particular tool. And here's the follow-up angiogram showing that the vessel is normalized, healed, and the pseudoaneurysm is away. This was a ruptured ACOM aneurysm. It wasn't addressed initially, presented to a small hospital. Was kept there for a while, transferred 2 weeks out from the hemorrhage, came to us. And so it's a ruptured aneurysm. We were thinking of coiling it, but it has a broad neck. And so in this particular case, because it's more or less a subacute presentation, we elected to coil the device, but also use, instead of a low coverage stent, decided to use a pipeline device. And you get a very nice reconstruction of this vessel. I think it actually gives you more security in coiling the device, so they can be coupled with coils. And this is the 6-month follow-up in this patient. You can see a very nice result. What about these types of aneurysms? So these kind of fusiform distal aneurysms of the PCA, of the MCA in this particular case. Here's a balloon test occlusion. You can see there wasn't much collateral coming into the upper division from the ACA. And so we elected to go ahead and try to reconstruct this with a pipeline, 2 overlapping pipeline devices. And here you can see the 9-month follow-up angio, complete resolution of the aneurysm, and still antegrade flow into both divisions of the MCA. A small pericallosal and we went and treated it with pipeline. There are issues, though, related to the treatment of patients that have recently ruptured aneurysms with these devices because of the necessity for the antiplatelet regimens. So you have to get everything in order. If the patient needs a shunt, that has to be placed preemptively. If the patient goes into vasospasm, that has to be dealt with. But it can be done if you are very methodical in your approach to this. And so here's a 3-month follow-up MRA. This was the slightly over 1-year follow-up angio, and you see that there's been resolution of the aneurysm. This is another case of a pericallosal artery aneurysm. And you can see 6-month follow-up angio, nice result. Here's another small aneurysm of the pericallosal. So distal aneurysms become more and more in the realm of this target disease entity. And this is the 12-month follow-up angio here. What about some vascular remodeling? So here's a more complex case, a distal supraclinoid carotid aneurysm, dysplastic. It circumferentially involves the vessel. You can see the anterior choroidal artery coming off of the sac of the vessel, which is why the patient was referred to us. And so this is angiographically what it looks like. We went ahead and pipelined it. Now you have to come up with a sort of a strategy. And the strategy here was that if we built a sufficient construct, the transmural resistance across the stent construct, and in this case we used 3 stents across this segment, would be sufficient enough that if we could keep the aneurysm from acutely thrombosing by putting the patient on heparin and ultimately advancing her to Lovenox, keeping her like that for a couple of weeks, that we could then slowly allow the aneurysm to thrombose, allowing collaterals to develop. And so here's the situation when she comes back later to be followed. This was a year later. And you see there are a couple of things. The aneurysm is gone. The anterior choroidal artery now fills through a collateral with a medial lenticular striate vessel. And the A1 segment is not actually occluded. We were able to puff a little contrast into it, but hemodynamically it's changed so that now the ACA is filled from the other side. And I find this very interesting, and this is very exciting because in this particular case, there's some aneurysms that you can address with essentially what amounts to an endoluminal deconstructive procedure, where you can rearrange the cerebral vasculature. So let's talk a little bit about the posterior circulation aneurysms. A number of years ago, I had the good fortune of treating one of the first patients like this with Dave Fiorella and Mike Kelly at the Cleveland Clinic. It was a young girl that came in with mass effect. We were very enthusiastic. We put this multi-stent construct across the device and ultimately had a great result angiographically, but then also looking at the cross-sectional, you can see here the mass effect over a period of time, 9 months, essentially dissipated as the aneurysm resorbed. We were very excited. A lot of people were excited, started doing all of this, and then suddenly this kind of paper comes out where they pointed out that it actually can be quite hazardous. And really kind of fortuitously, this comes down to not understanding all of the anatomic features of the device, so of the disease. So there were some features of that initial case that suggested now this would be a successful case. that the aneurysm, even though it's massively large, even though it involves a large segment of the basilar, is really situated between the icas and the superior cerebellus. So there isn't really a runoff vessel from the sac of the aneurysm to keep it alive, and it can thrombose very easily. And because of its growth, the vessels that were ultimately issuing from that aneurysmal segment have long since occluded and been collateralized. So there's some features of this case that would suggest why we were successful in that one. In their particular case, it was kind of a dismal outcome. Then you see other groups publishing better results, yet other groups publishing better, and it starts to be confusing. How come some groups are doing well, other groups are doing miserably? Well, the problem is that we're talking about different species of cases here. And that's where it comes down to, you have to understand the individual patient, the individual pathology, all of the anatomic features of this disease, of the specific case that you're treating. And so this group here are easily treated with flow diversion devices. We're easily treated with endoluminal remodeling. Others are not, are very hazardous cases. So here's one, a PCA aneurysm. The aneurysm is actually much bigger than this. You can see it's displacing the superior cerebellar here. This is a very nice case for overlapping two pipelines across the aneurysm neck. Here's the result at 6 months. We're starting to get a little bit of loss of the mass effect. And here it is at 3 months. You can see that the mass effect between the two vessels is going away. And so this works very nicely. Here's another case. It's a VB junction, actually a fenestrated basilar here, but it's below the ICA. So there's nothing here in terms of an important vessel issuing it from. There's nothing to keep the vessel alive. And so this can be very nicely. Someone had tried to deconstruct the right vertebral artery long ago. The aneurysm came back. It's mostly thrombosed, so there's a large mass here. But it's an easily addressed aneurysm. It's between the pica and the ICA. And so this can be very nicely reconstructed and addressed this way. So you have to know your disease, and you have to understand where your tool will be effective in the disease. This was a different kind of case, a large, complex, holobasilar aneurysm that we got into initially. We put a construct, actually had a very nice anatomic result. I'll show you, this is just showing the CT, how the device insinuates itself. This was a month later. We did an angiogram. It looked great. The patient was doing well, except starting to have headaches. Ultimately started having some issues with ataxia. You do the CT scan and you see there's runaway hydrocephalus. This is before we knew we had to put a shunt first. And so you stumble into these complications, not understanding the disease and the implications of the therapy. Because there's going to be a period of time after you put this device, before the erythema has grown across the neck, that you're going to have a large thrombose mass that's going to have an exacerbated mass effect and is going to lead to kind of a hydrocephalus picture. Here's a different case. Again, the ICA is coming from the belly of the aneurysm. We put the stent in. This is what she looks like 24 hours later. We were excited about this before we understand, then poof, it ruptures, and you end up with this kind of case. So there are a number of these cases. The treatment of this disease is in evolution. This is one of our more recent cases. Again, very complex case. We now know that we have to put the shunt in first so that we don't get into issues trapping the aqueduct of Sylvius when the mass expands. And then we can go about treating it. But I do something more now. I also will coil the aneurysm. And so we put the device, the construct in. We coil around the mass. This is the immediate result. This is 3 months later. We have this really good result in a man whose neurologic symptoms, nearly quadriplegic, is improving. But you have to remember, this disease is like cancer. It's not just here in the basilar artery. He's got an aorta that has a huge ascending aortic aneurysm. His cardiac output is 15%. So yes, he improved for 12 months. And then he went into congestive heart failure, came into the hospital, became septic, and died. So this is like cancer. You have to have, there's an endpoint. You're trying to do something for a patient so that maybe he has a better quality of life, but he's not going to live forever. There's going to be other issues. And so I'd like to just kind of end on this note. The last piece in deciding and rationally using these tools is a pragmatic, honest assessment of what is the risk-benefit ratio. Sometimes the disease is horrendous, and so, despite a high complication, it may be worth taking that risk. At other times, no. If it's a cavernous aneurysm or something like this, maybe no. And so that has to be assessed. And one of the issues that we came and learned belatedly was about the thrombotic complication. And this was a case that we treated, a petrous segment, a large aneurysm, had a fabulous result at 6 months, follow-up angio, pulled her off like everyone because we're treating like a cookbook. We're not thinking about the disease, the patient, the specific aneurysm. We're just like 6 months, now we're done. Okay, she comes back later, next follow-up angio, asymptomatic occlusion, but it's an occluded vessel. So what's the message here? The long constructs are going to take a long time to endothelialize. It's going to be a while before that intima can grow across that ocean of an aneurysm. And so during that time, these kinds of cases may need an individualized antiplatelet regimen. The antiplatelet regimen is likely that it's going to need to be extended past what our cookbook says. It's not the 6-month turnoff. And so all of these things, again, come down to individualization of the disease and what we expect to do with it. So in concluding, let me just get to my conclusion slide because it's very important to show. So the thing that I guess I get very excited about, when I was a child, I lived in kind of a rural area. I'm not leaving without this slide. And so an experiment more or less was performed. Let me see, I probably have it in a different. I'm going to open up a different one. Just give me a moment, please. So out behind our house, or my dad's farm, was a bicycle that was laid up against a tree long time ago. This is a picture taken a couple of years ago. The camera is basically at my eye level, so I'm looking up. And the inert material of the bicycle, the metal of the bicycle, has been incorporated into the tree and then carried distally. So it's up about maybe 2 meters, 3 meters, 2 meters, 3 meters, yes, high. And so never underestimate, and I think the beauty of what we're doing now with the endoluminal tools is that we are taking advantage of the biology of the blood vessel, and we're trying to learn to manipulate that. And so it's the beginning, like Jacques implied. There'll be new tools all the time, but it's the beginning of what I think is a dramatically altered paradigm for the treatment of cerebral aneurysm. Thank you.
We're going to continue, and then we make a question together. Dr. Demetrios Lopez?
No, it's
Sorry. Dr. Christian Tasser will talk about surpass flow diverter. Thank you, doctor.
¿Qué es? ¿En su computador? Está aquí. Muy bien, ya está. Gracias. So, yeah. Thank you for the introduction and for the invitation, Luis, to allow me to present on the surpass flow diverter here in Madrid. It's going to be a rather technical presentation, and I will show some clinical cases with this flow diverter, which has been available in Europe since 2012. The surpass flow diverter is a self-expandable braided device which is And this is a major difference when compared to the other flow diverters available on the market. It's preloaded in a microcatheter, which you can see nicely here on this image. So actually you have an outer catheter, then you have an inner catheter, which you can see here, and in between is the flow diverter. The flow diverter is delivered by pushing back the outer catheter and advancing the inner catheter. It's available in sizes between 2 and 5 millimeters, and the 2 millimeter device comes in length between 12 and 20 millimeters. Quite nice is the fact that we have really long flow diverters available. advantages. First of all, the delivery catheter has an outer diameter of 0.53 inches. Stiffness can be an issue, so you need the triaxial access, which can be quite demanding sometimes. And the Surpass flow diverter is not resheathable, so there is now Streamline as an answer to these drawbacks. The Streamline comes with a more flexible delivery and is resheathable. It has been launched in Europe in mid-December. I myself did 2 cases with the Streamline flow diverter so far. So these are the changes which have been done to the delivery catheter, and it is supposed to be able to navigate through very narrow curves, as you can see in this case from Baltimore. The second point is that the Streamline flow diverter now comes as a resheathable flow diverter. These images are already used actually feature, and this recapture feature allows to pull back the Surpass flow diverter before you and you, up to 80% of the flow diverter length. So this is how this recapture feature looks like. And let me summarize again the features of the Surpass. It's a braided cobalt chromium flow diverter with lengths up to 50 millimeters. It comes preloaded in a microcatheter. You need a triaxial access, deliver it over 14 inches micro wire. You have a 2 millimeter system, and the Streamline for 3 to 5 millimeters is resheathable. Thank you very much for your attention.
Okay. Sí, que tiene hacer una pregunta que luego
Oh, hace una pregunta.
Sí, preguntas.
No. We make the question.
No. Yes? Okay. Question, or do you want to talk?
Yes.
Demetrios? Is he Demetrios?
No. Demetrios Lopez? No.
It's lesioned. No problem.
Professor Saroja will talk about different flow modification techniques and what may be the future. Thank you, Professor.
Okay, I'd like to first start with thanking Luis, and I wish you best of luck and health in the next year, hopefully, and next time we go the game together. Okay? So I had a confused topic actually. So irrational use of flow diverters. Anyway, just joking. And this concept focusing on flow modification, diversion, functioning from out of the aneurysms. Grafting, definitely, which was the most ultimate flow diversion. Then it started with homemade flow diverters. Eso. It was showing there, right?
Sí, sí, tiene que detectar pantalla FHFH.
Just,
No, Sale Roche, pero no hace nada.
Okay, we can put in the number 6.
2.30.
Yeah, we can do that.
Ah, okay.
This one, ¿verdad? Este.
Hey, sorry for this trouble. I just continue. Basically, the story started with the stent grafts, which was the most origin. Then it continued with the telescopic stenting, which was basically our homemade flow diverters. Then the dedicated flow diverters came, and now we have another way of flow modification from the sac of the aneurysm. And it can be used in some very selected cases, both in combination. So, although the flow modification concept certainly created a new and different avenue, we still have problems. You just see some problems, and we have also some certain decision-making problems with the availability of the different devices for one aneurysm. So if you look at our numbers, we have done more than 500 patients in the last, I would say, since 2007. Basically, our homemade flow is just limited because it was very selected cases, and most of our experience with dedicated flow diverters and the pipeline. So we really still don't like placing pipeline in the mid-basilar and high-basilar trunk. So we still do not do, and if we don't have to do it. So basically, and we still use our homemade flow diverters in the mid-basilar and distal basilar aneurysms. If it's basically, this is a different way of doing flow modification. So without mesh density, you basically change the wall geometry and wall pulsatility without changing the mesh density. When you place triple enterprise or triple solitaire at the neck of the aneurysm, your coverage is very low actually. But the way you change the flow and enclose the aneurysm is basically because of the geometrical change and wall pulsatility change. So this is actually very good advantage in some cases. For example, this is a partially clouded giant aneurysm, came comatose with a lot of mass effect. You see the brainstem compression in MR with the edema. So I strongly believe that in those patients, telescopic stenting, that's what we still do. This was done actually, and for telescope enterprise, and 6-month control, the patient is neurologically intact. And the flow modification causing the flow, the remodeling of the aneurysm sac should not always end with the perfect reconstruction. So this is not a perfect reconstruction. There is an aneurysm remnant, but we don't care. We don't even treat this patient. We just still follow this patient up. And if you look at the pre-treatment MR and the 9-month control MR, you see actually the patient is cured. So you don't treat the aneurysm, you treat the disease in this particular patients. So having such occasion, having the telescopic stenting and having the option of treatment with just changing the geometry, like in this dissecting pike aneurysm without too much mesh density, is a big advantage. Just keep in your mind. So if you look at our telescopic stenting data in between 2005 and 14, starting of 14, if this is mostly for posterior circulation aneurysms, since we're not placing flow diverters a lot and in the basilar artery, and mostly is the 48% of these patients were basilar artery. So if you look at our flow diverter experience, which is mostly pipeline, we have a very limited experience with Silk, and now we have some experience with FRED2. And this is not, you can see easily that we don't put a lot of flow diverters in the posterior circulation. Actually, our idea probably started since because we have the first mortality because of the jail branch, because closed and patient had a large infarct and died with posterior circulation aneurysm. So we've been still doing the telescopic stenting in those particular cases. And actually this was supported very well within showing that the complication rate is very much higher in the posterior circulation. So we have a very limited number. It was actually just 10 patients was done with pipeline, and we have one mortality, and which is basically 10%. So this is very rare. This is one of the cases, was done with the pipeline, good reconstruction. It's actually mid-basilar. I would still do actually telescopic stenting. This was not my case, one of our team members done. Basically, this can give you the same, you can have the same result with telescopic stenting without too much mesh density. There are some cases, obviously, the small aneurysms, and you need this remodeling effect because the telescopic stenting is not effective in the small aneurysms that you need the flow remodeling effect of the flow diverter. So in very, very selected cases, we have to take the risk, and to be able to remodel here, you basically place a flow diverter and even in the top of the basilar of the top of the basilar artery. So our flow modification of choice is called telescopic stenting in the posterior circulation, especially in the mid-basilar and distal basilar. As you see, you can have very reconstructive results in the late control angiographies. The complication rate is much higher than the regular flow diverter treatment because this series included the large and giant fusiform vertebral basilar aneurysms. I think this is a different disease. Peter Kim was just alluding this. I think this disease is not an aneurysm disease. This is a form of atherosclerosis, which we can call in the peripheral intervention radiology as a arteriomegalic atherosclerosis. This is a totally different animal, and even you have a perfect reconstructive result, like in this case, and this died at the 7th month, 1 month later after we had this perfect angiographic control, because his clinical finding didn't change, actually continued progressively worsening. So we did not treat the patient in those particular patients. So the flow modification taken with Hommel, I've described, is called Y-stand flow diversion, and which we cannot coil because of the mass effect, already mass effect, and actually most of the cases done with L stent, the crossing point and creates very efficient by our flow studies. So this has creating a basic way, and this is a mark just diversion caused by two closed cell stent crossing over the basilar bifurcation. This hit point creates a hit point for the flow diversion and does the most effective flow diversion actually. So this was another case, and very tough aneurysm was ruptured 1 month ago before it came to us. Maybe I showed this before. Basically, it just sometimes causes perfect progressive deconstructive reconstruction, like in this case, end up having the right PCA occlusion while the aneurysm is just being remodeled with the effect of the Y-stent flow diversion. And this is the 5 years control angiography showing, again, a very effective flow diversion, very effective reconstruction of the flow diversion at the top of the basilar artery. The PCA is gone because of the posterior communicating artery was just filling from the right carotid, and there was no flow demand in this right PCA. So with dedicated flow diverters, you heard a lot. I'm going to go past here. Basically, the main problem in this dedicated flow diverters, it was designed to solve the problem of the large and giant aneurysms, and we end up having the biggest problem actually in the large and giant aneurysms. So why? Because we had in some particular patients the problem of the clot and its inflammation effect. So this was not well understood, why this is happening in one patient and it's not happening in other patients. So there are a lot of variables. Basically, the therapeutic effect of flow modification is a function of the anatomical course of the parietal artery change caused by a flow diverter or stent from one geometrical plane to another, and the change of vessel wall elasticity and pulsatility, and the porosity change at the base of we can calculate somewhat. However, we cannot calculate the biological alterations caused by the endothelialization, the flow diverters, which is called endothelialization and intra-aneurysmal clotting. In some patients, it just goes wild and kills the patient. And we knew that actually this is going to happen. This is our very early stent graft case. It was a 27-year-old male presented with intense headache, left hemiparesis, slight swallowing difficulty. So we treated this particular patient with a jaw stent graft, and this was the most ultimate flow diversion. Actually, it's not flow diversion, it's just the exact exclusion of the aneurysm from the circulation, like surgical clipping. However, although the treatment looked right mechanically, this is the post of first day, the biology did not work in that way. So the aneurysm just swollen, and the patient started to lose all lower cranial nerves. He got intubated, he got gastrostomy and everything. He had a horrible 2-3 months, slowly recover, and this is the 1-year control actually in this particular patient. So you can imagine if we have a little bit of flow into this aneurysm, this was going to rupture. Basically, this was not going to rupture. That contrast, that brisk flow is going to go out of the aneurysm. So we have some solutions beyond medical solutions, like putting the patient on steroid regime and having a very effective anti-aggregating treatment to control the clot. First, coiling with flow diverters. Obviously, we start to do all to control this problem. Or, as Peter alluded, multiple flow diverters, and like in this giant aneurysm, we placed 9 telescope pipeline till we stop the flow into the aneurysm. That might be another solution. or just stage in such particular patients that our experience telling us that this is going to happen. It's a giant aneurysm in a relatively narrow neck. If you place a flow diverter, the clot which is going to form there may cause a rupture. So basically, you can first palliatively coil, wait for regrowth, and then 100% sure that this is going to recanalize, then place a flow diverter and have a reconstructive result at 6 months. So this is another way, or you can do this stage treatment with flow diverters. First, this is again a giant partially clotted aneurysm. You treat with telescopic stenting, basically have some flow modification effects, some shrinkage of the aneurysm, then complete the treatment with the dedicated flow diverters and coiling, and have this fine reconstructive result in 2 years. So basically, you can control the clot with staged treatments. So although flow diverter is designed to treat large and giant aneurysms, and you see from Dimitrios, there will be I think that it was a great revolution for the small parophthalmic blister-like aneurysms, for fusiform dissecting aneurysms, multisegmental disease, but most importantly for the aneurysms with a vessel coming from the coming off the sac. For the aneurysms with a vessel, important vessel, coming there from off their sac, which was the major limitation for endovascular treatment. So basically, the process that we call while the aneurysm is being thrombosed is flow remodeling. So it happens in a certain period of time from one person to another person. It gives you a good reconstruction. And especially in bifurcation, this process is strongly affected by the flow demand of each bifurcation vessels. And basically, flow remodeling either simplifies the bifurcation, let the occlusion of the aneurysm, and one of the bifurcation branches coming off the sac. So which we call this progressive deconstructive reconstruction. So basically, this is happening in a progressive fashion, like in this ruptured dissecting ICA terminus aneurysm, which was actually Işıl's decision. I was just thinking that the coil here, basically she just placed, because it was treated not in the acute stage, just 1 month later, she just placed the one flow diverter, and this is the 2 years control, showing that the progressive deconstructive reconstruction. So if the flow demand of this critical integrated vessel is strong, it keeps the patency of that vessel, as you see, and with the complete aneurysm occlusion. And this process is not always, like telescopic stenting, is not always completed with perfect reconstruction, but remodeling of the aneurysm sac may end up with stable remnant that become continuation of the vessel with flow demand, as we see here. This is the 6 month, and this is the 1.5 year MR angio, which was from this large right MCA aneurysm after the pipeline treatment. So with this revolutionary aspect of flow diverter treatment, it looked like there could be a very strong future for very complex cases. And there is a place for flow modifiers and flow diverters in the MCA bifurcation. And this concept, for me, has already changed the treatment strategy for M1 aneurysms, because knowing that, you know, it just closes the aneurysm and just keeps the vessel intact, as you see, with the progressive remodeling. And this is very revolutionary change, actually, in the aneurysm treatment, of course, in unruptured aneurysms. And pipeline either keeps the old bifurcation vessels with aneurysm occlusion, depending on the flow demand, as you see here, or aneurysm occlusion with making the critical trunk hypoplastic, like in this particular MCA bifurcation aneurysm with a tough superior trunk. So basically the easy inferior trunk was stented, and this is a 1.5 year control. And these are all happening because of the flow demand of the vessel. And this is the asymptomatic occlusion of the critical trunk. In the 6-month control, you see it just starts to fill with the pile collaterals. So in particular cases, this process ends up with no maybe fully closing of the aneurysm, but with remnant, which is stable by the time. So basically, look at this, the left MCA, very narrow neck in this plastic area here, and this is the inferior trunk, basically, and this is the 15-month control. If you do look carefully and do 3D rotational, here you see the aneurysm had such remodeling, basically the sac of aneurysm become the continuation of the inferior trunk of the MCA. So we need a new classification. Işıl is going to talk about that. So flow remodeling can show an interval change from one from the another in the later angiographies also. And as you see, this is the 6-month control in this particular patient, which I just showed. But in a 1.5-year control, it ends up with hypoplasia of the superior trunk. However, in the 6-month control, it was like continuation of the superior trunk. So after Jack's presentation, I just wanted to put these slides. I mean, we've been yelling in the all neurointerventional meetings in the Val d'Isère, many of them probably remember, about the meticulous testing, and anti-aggregans response is the key of success. And unfortunately, the neurointerventional world has been very stubborn in that issue, and they pay the price. So basically, we did not do a single patient since 2006 without the light transmission aggregometry showing at least 50% thrombus inhibition. And we did not place a flow diverter MCA bifurcation. We did not do a Y-stand assisted coiling. We did not do just load the patient a day before with 8 tablets, do a lousy Acumetrix testing. Okay, then do the pre-treatment. Then you have a 10% complication if you do that. Our rescheduling rate in the Y-stenting and flow diverter cases has been more than 25%. So 1 every 4 patients were being rescheduled because of the fluctuation effect, because of meticulous testing was showing that the clopidogrel response is not enough. So we stopped using clopidogrel since 3 years because its unreliability due to its very fluctuated effect. You can have 1 patient in the morning, they have a good response. In the night, there is no response. And then the patient had a stroke in the night. So basically, we have changed our strategy in the last 3 years, and I strongly suggest you to change it. It's not anymore double anti-aggregating agent. We only use prasugrel. We use in a half cardiologic dose. We load the patient 30 milligram instead of 60 milligram and use 5 to 10 milligram maintenance depending on the LTA result. And more than 300 patients were tested already with LTA with no low response or resistance, and there is no spontaneous cerebral bleeding, knock on wood, during this period. So then, if you are very meticulous, you can place flow diverter in MCA bifurcation. Of course, there are problems. Of course, there is a complication, like in any procedure. But I believe, you know, these were a very selected group of patients from our large experience. And in the last 3 years, in the cases we have done in the MCA bifurcation, the complication rate is 0. However, all complications developed in this particular experience, which was the 3.2%, what happened during the clopidogrel time. So the last flow modification technique is the Işıl is going to allude as the intrasaccular flow modifier. We're all excited about that, and we've been doing a lot of consecutive angiographies. So it just shows another way of flow modeling, and it mostly ends up not with perfect reconstruction with these so-called aneurysm remnants. However, basically those remnants, when you look those by the time, they stay stable. So we need to discuss a lot, and we need to have a new classification method. It seems those remnants are not recanalizing. This is our early result from this study. However, this technique needs very meticulous web device selection using flat panel CTA intraoperatively. If you just look at the aneurysm and just pick okay, this is 5, just give me a 6. If you do like this is a big problem. So the last flow modification is in very selected cases. Basically, it's for complex aneurysms, is the combination of the pipeline and web. Like in this particular case, basically this technique offers much faster and more reconstructive remodeling. So you see the result much quicker. And basically, if you place a web and at the neck a pipe, you have this remodeling effect. You have this vessel stayed patent, and the aneurysm remodeling basically resulting in the aneurysm sac is becoming continuation of that branch is happening much faster in with this particular technique. And if you look at this aneurysm, and this is a very complex superior, the right MCA bifurcation aneurysm, and basically treated with web in the sac and pipe at the neck, and this is just 3 months control. And look, and aneurysm sac show such a remodeling and superior trunk as a big continuation of the aneurysm sac. So basically, this is the 3 months control, and this is the 9 months control, showing that the superior trunk is still patent because there is a strong flow demand, is leading the aneurysm, is showing such a progressive remodeling that basically that remodeling making the aneurysm sac is becoming the continuation of the superior trunk. So this is the 18th month MRA. Are we going to call these remnants? I'm not sure. So what will be the future? Future is my personal predictions. Future is the stent surface. They need to be modified with different technologies, letting us to use them without anti-aggregating agent. With advancement in microblading technology, with more amorphous, adjustable, and very soft intrasaccular devices will replace coils. Definitely, I strongly believe that there will be no coils in the near future. And those intrasaccular flow modifiers will be combined with extrasaccular stents with their new surface modification. So having different treatment options increases the success of endovascular treatment. And this was a very recent patient. It's a right M1 aneurysm and this left MCA bifurcation aneurysm, 65-year-old, unruptured but severe headache. And you just go there, place your intrasaccular modifier and place your extrasaccular flow modifier in the right M1. And basically, this is so simple. And I love to do this. This is a Y-stent assisted coiling. I am the one developed many of these technical details of these procedures. I love it, you know. I love it. However, I'm not sure if you're going to be doing it. So the future should be simplicity, as Leonardo says, and the simplicity is the real art. Thank you very much.
Thank you, Shahrukh. And now, caipirinha presentation, no? Demetrius, caipirinha presentation. Good.
Perfect.
Fast, eh?
No problem.
Thank you.
Well, it's great to be here, and I really appreciate the invitation again. Thank you so much. And I have 2 topics that are probably one of the most interesting thing for me in the last few years has been the focus on blister aneurysms as well as on fusiform basilar aneurysms. And the reason why I like this is because I don't think we have good solutions for this. I will share with you that everything I'm going to show to you is these are attempts to treat a very difficult problem, as you have seen today. But it's very important, though, that when we talk about this, we focus in one disease in particular, because we cannot mix this with a blister or a sidewall aneurysm. When we talk about the issue with an aneurysm that is involving the vertebrobasilar system, I'm talking about something that more like the picture you see here in the basilar arteries, involving multiple vessels, is involving a significant extension of the basilar artery. In this case, you have actually the whole, the lower third, the mid third, and a little bit of the upper third of the basilar artery is involved on this disease. So that's the disease we're going to talk about. And this is, for me, a problem that is relatively rare, but when they come, you never forget them. They're very difficult to tackle this. The problem with my talk today is that unfortunately, you cannot, there's going to be a few points you're going to take home, but it's very difficult for you to consistently say, I will do this when I get home and I get the same results. And I think this is the biggest problem that we have today, is that in this particular area, we are every time using a different treatment. It's very difficult for you to consistently use the same technique. We use all the things we learn to treat these problems. But I would like to point out a few things we learned over the years. One thing then is, for me, is to look at the natural history of this problem. So if you look at the vertebrobasilar fusiform aneurysms, these patients are not going to do well long-term. So the most important thing for me is that between ischemic disease, hemorrhagic, the risk of bleeding, and the risk of mass effect, these three problems, these patients will become symptomatic over time. So I will pose to you, and this is very controversial, that it's better to treat these patients before they become symptomatic. So if you wait until they become symptomatic, you're going to have a hard time to get them back to their baseline, or you may never get that back. So if this patient is already in a wheelchair or not be able to swallow anymore, you're not going to have a good outcome. So I think what's controversial here is that our treatments many times can be dangerous to these patients. So we need to tailor our treatment to be less dangerous possible, effective, but not necessarily a cure in the first treatment. And the point of my talk today is that as we learn about this disease, it may be wise for us to do a staged treatment, starting early on the process and the disease. As soon as it gets diagnosed, then you start early to treat these patients. Because if you let the natural history take care of them, they will not do well. So for me, it started with a MAGIC case that we use a MAGIC wall stent. And this case was a very impressive result in the 1990s. We was one device, and this aneurysm had an amazing result. This was the light in the end of the tunnel for me. I think at the moment we saw that we could treat such a disease, we felt that we had to work on this treatment. Unfortunately, we could never consistently repeat that. After that, we had multiple other cases that we could not get good access with the devices we had. We had to do open surgery combined with endovascular. Was not consistent at all. After learning a lot from this, I think that what Dr. Moraes spoke earlier today regarding using the simplest treatments and adding that to what we have today, I think this is very wise. And I think that having a combination of therapies will perhaps help us to treat this early on without having the morbidity that we normally have using, let's say, only flow diverters overlapping on this territory. So what I'm going to share and propose to you is that a variable construct using a low coverage metal-to-artery ratio plus a high metal-to-artery ratio may be a wise way to treat this. But the most important is the staged approach. not, for example, sacrifice the vertebral artery contralateral in the first procedure. If you would stage that, it may be also a wise approach, especially if the patient is asymptomatic or early on the disease. For me, this, of course, was clear. We had the initial publications. We're using only flow diverters, and they were somewhat predictable, but they turned out to be not very good results. We had also data from Intrepid. This is actually a reanalysis of the Intrepid now with actually 95, not 55 cases of posterior circulation, and the number of morbidity mortality was around 13.2%. And so it is clearly a different disease, and here is not only separating fusiform aneurysms, this is a mixed bag of posterior circulation. We recently, this is in the cover of a journal of neurosurgery in November, we were able to publish our experience, and so this publication shares what we learned with this. And what are the technical considerations? What we're talking about here is that we want to protect the highest density of perforating branch, which is towards the top of the basilar, or if not necessarily the highest rate of perforators, the most significant neurological morbidity would be. So this area on the more distal portion, the basilar, we would use a low coverage, maybe 6% metal to artery ratio. And in the lower portion, we will use perhaps a higher impact, maybe a 30% coverage. The idea also was that we don't want the one aspect we cannot control is the, Saru showed very well, the aneurysm sac. If that thromboses, it will cause symptoms. So you can argue that one approach would be, well, we'll do a preoperative decompression of the posterior fossa, just to tolerate the swelling of the cerebellum, for example. Or you can say, I'm not going to do this in a stage fashion. I'm going to keep the vertebral artery going to the aneurysm sac. So you not only create an endoleak, but you do that because you want a slow thrombosis of the aneurysm sac. And then when the patient is becomes, assuming here that the patient is not already completely symptomatic, if you get this in an early stage, you have time to do that staged approach. And then, of course, the antiplatelet therapy, I think this is highly debatable, and that just goes to show we have a lot to learn, but you have to use a good antiplatelet coverage. Now, I'll show you a few examples. First one is a case that we delineated, and this is a little bit, we try to use the ICA. Below ICA, maybe safer to use a flow diverter than above ICA. And so we try to place the first flow diverter below ICA, like you see the plan here. And in the deployment of that device, you not infrequently will realize that when you do that, you're deploying the flow diverter in the middle of the disease vessel. So you may not have a good place to anchor the device. So that is another thing that the low coverage device may help you. You can argue, oh, the PCA doesn't have so much disease, but the top of the basilar has. When you put the flow diverter there, you will not anchor very well. But if you have a 6% or a smaller stent, you can deploy the flow diverter inside of the stent and use that as an anchor for your flow diverter. So this is how this would work. You have this low coverage, in this case is Enterprise, and then you see a little bit of overlapping between the flow diverter and the Enterprise. That is enough to anchor the flow diverter inside of a disease vessel without having to deal with a mismatch, a significant mismatch, and decreasing your metal to artery coverage if you have to mismatch the size of the flow diverter in the lower basilar. And this is how this construct would look like, low coverage, high coverage. Now, the patient did okay for 2 months, and this is probably the biggest downside of such a technique is that these patients have to be followed more closely. And the patient was not getting better. He got worse of headaches, the diplopia got worse. So in these cases, if you bring them back, you have the chance in a second stage to occlude the vertebral artery in the contralateral side. So we did not take the vertebral artery that was incorporated in the aneurysm early on. We took that in a second stage because the patient became symptomatic. And you can appreciate then now the classic construct. This is what many of us used to do this in the first stage. And now I'll tell you how much we learned about this. Remember how this disease looked like. We had the flow diverter ending right about here. So there was a development of a new aneurysm as we waited for this. So as you're following this patient, you had to patch this and treat this stage. But this patient now is doing well. It's just you're having to take the time to follow up. And in this case, now we're adding coils and kind of patching, tailoring that treatment. So you have an initial construct that had some flaws in it. The area that has 6% coverage is more prone to have recurrences or problems. So you then treat them as needed. And this is how we end up, doing these things, coiling in different stages, the area that is covered only by 6% coverage. I did add a second enterprise to the area, and Saru alluded to that, to use multiple low coverage, but you don't take the hit to use a high coverage from the beginning. You can increase that as it goes, and that's probably the biggest lesson of this. And this is how we look now, completely, how this disease, maybe not as pretty as a flow diverter reconstruction in the top of the basilar, but I'm okay with that. And this is just showing the progression. I think the clot progression, the thrombosis, the control of clot thrombosis inside the aneurysm sac is the biggest trick for us moving forward. Now, let me show you another case that has a more complex, because there are two aneurysms involving the ICA, one involving the ICA and the other one the vertebrobasilar junction. In this case, the patient's early on in the disease, and what we decided to do here was to first stage to build the hybrid construct, second stage to coil the ICA aneurysm. So the first stage, you can see that the pipeline is very little to anchor. You don't want to go with the pipeline to the top, but very little to anchor. So in this case, the enterprise will help a lot to hold that in position. You can see that the pipeline is barely fitting between the two aneurysms here. And then the enterprise is what is helping me to create enough of a bridge to allow that to anchor. So you can see how the pipeline didn't fall into the aneurysm, stayed in there. And we allowed this to stay just like it was, enterprise and pipeline in the first stage. And then the patient came back a few months later, and we did a loose coiling of the segment that had enterprise across in the ACA. And then you see here, the contralateral vertebral artery is not sacrificed. So this vertebral artery is still going into the aneurysm, and that's some purpose. And this is the remodeling that we got. So you went from this to this. And this is the construct now on CTA. The contralateral vertebral artery is open, and we are able to get away with this construct. So variable arterial coverage, that's one tip, and this is more or less what we have today in our shelf. So this will continue, as I predicted that there may be different options we have, and we can use that variable coverage. The antiplatelet management is another area we need to continue working, and if there's going to be one antiplatelet or multiple. I think the imaging, if we do OCT, I think we'll learn more about where to put the lower coverage and the higher coverage. So intravascular imaging, I do predict as one possibility that will help us with this type of treatment. And this is the type of image you can see. This is a pipeline and the basilar artery. And I really enjoy seeing that then you do a smart choice of what kind of coverage you need to have. So I would like to conclude this topic, and I hope to be very challenging, is that first of all, consider this disease a very poor natural history. When you talk of vertebrobasilar fusiform aneurysms, these aneurysms are likely to have a high morbidity and mortality if left untreated. I recommend that we consider to do safer, staged, earlier treatments, and I think that the proposal of a variable coverage may be a gentle or a better way to do this. And also it incorporates us not one treatment fits all. Here, what you have to do is to tailor, and ideally, if you have that imaging to tell which perforators are involved or which brains are coming out of the aneurysm, you have to then tailor your coverage based on that. I think the progressive thrombosis of the aneurysm sac is a very challenging topic. And to do this gradually, how to control, we can control how much metal we put across a perforator, but you cannot control the clot inside of the aneurysm sac. And that progression of thrombosis is what we're trying to do slowly by allowing the sacrifice of vertebral artery to be staged. Now, the intravascular imaging is a topic of research, and I think that's coming along, hopefully, for us in the future. I'm going to move on now into another topic that I like. How's my timing? ¿Está bien? Está bien. Gracias.
It's time to take a coffee break. Anyone have a question? Dr. Peter Nurse.
Dimitri, I've had this discussion with Adnan, and I guess, and I have no more insight than anyone does about this, but more or less because I think that what we're doing in the fusiform basilar is experimental. I've been persuaded to wait until the patients become symptomatic, and I think that's a fundamental question. What I worry about in this approach of attacking the minimally symptomatic or asymptomatic patient and doing sort of an under-treatment, partial treatment, is that in reality you're not doing anything other than you're getting the patient out the door and you're saying, I had a success. The disease evolves, differently in every individual. And many of these patients, if they're just left untouched, go quite a long while. And so are you fooling yourself by thinking that you're actually contributing to an improved natural history? Or the patients keep coming back to you and they keep growing until you finally get enough of a definitive construct. In the meantime, if you've littered the basilar artery with all kinds of devices, when it comes time to put a pipeline or something, it's going to be more complicated. What's your insight? I'm not saying that this is the right view. I'm just saying it's a worry that I have because I hear the litany of, well, I'm now kind of approaching the patients earlier because I had failed problems with the really advanced cases. But you don't know, many of these are young individuals, and we might not have bumped into them until they were 50 years old and in bad shape. They might have just been carried for quite a long time.
I think that if we had a marker or a way to know which patients are going to progress to symptoms, that would be one way to address that. I do feel that I don't think that we have one strategy or will ever have one treatment by one type of stent that will be able to treat with it. So I think the solution to this will be a variable coverage somehow. I think that the morbidity that we know today using one device only, it's perhaps not acceptable for most of us. I think the other thing that I don't like is having the uncertainty. And anytime I do a surgery, I want to know that the outcome is, I can somewhat predict what's going to happen. And I feel that many times when I place a flow diverter mid-basilar or top of the basilar, I'm somewhat crossing my fingers that things are going to be okay. And I think that I don't like that. I think that if I can have something that, and it turns out that even Enterprise or Neuroform in the top of the basilar, many years ago, we didn't know what was going to happen. And now we just have more confidence on that. And maybe what I'm speaking today is based on today's knowledge of how the devices perform. This is what I feel more comfortable applying this. Using a treatment like this, you're very right. I may be fooling myself, but at this point, the follow-ups that we have, we're about 3 years from the first cases that we did this. I've been very pleased how we were able to stop. They're not completely asymptomatic. Most patients that we treated had diplopia or headaches with diplopia or something like that. The headache, I give you that. But I think the diplopia is a sign that something's happening already. The other thing I feel is the patients that we waited to have symptoms, we never got them back. Always they get worse, you know, like over time, you put a flow diverter there, you thrombose more than aneurysm, they get symptomatic immediately. You know, it's just being very unsuccessful. So I think your point is very well taken, and I wish I could answer that better, but time will be, I think, the best way to go about this.
I guess what I'm saying, if you take morbidly symptomatic patients and you treat them with enterprise, you lose. We also are losing with pipeline too. So we don't necessarily, we're still having to experiment with what is going to be working. When you find something that is morbidly symptomatic patient, then you have a solution. In the meantime, like treating a minimally symptomatic patient, you can sprinkle holy water.
But Kim, if you think about this, but if you become symptomatic from this disease, means that your quality of life in terms of walking, the ability to walk or the ability to swallow, these are the two things that we see, you know. Outside of that, you may have the, let's say, the double vision, but those things a lot of times you can compensate for. But when it comes down to the inability to walk and the swallowing, I think you lost the game already. By that time, when it gets to that, you cannot come back.
Well, I disagree. I think you can come back. We have a couple of patients that have
Did you see one?
I have a couple of patients.
I never see. That's what I was going to ask, actually.
So the issue that I have is that
So I think that when you treat, so when patients like this would come to us in all stages, we'd see a big holofusiform basilar aneurysm. Now, let's not talk about the VB junction ones or the top. Let's talk about the holobasilar going through the ICA segment. We used to tell the patients, okay, you have an 80% likelihood in 2 years you'll be dead. That's what we would just say to people. We would say they rupture or you're quadriparetic and you become aspirate or something like that. In reality, most of them died of an MI or they died of something else because they all have bad peripheral vascular disease, to your point. But then, you know, in some of the minimally symptomatic, we would tell that to even the people that had diplopia. Then for whatever reason, we started following a few of the patients. And now I have some patients that have gone 5, even 8 years. And yes, they have gotten slowly worse. But I've been afraid to treat them early on with a kind of half treatment because I know many patients that came to me for pipeline came with indwelling enterprises, things all over the place, making it very difficult to seat the pipeline in the parent artery. And so I think that when your metric is that the patient doesn't die next month and that they survive the hospitalization, yes, you can take asymptomatic patients. You can put all kinds of things in them. They will live and they'll go out and they'll be okay for a little while because the symptoms wax and wane. But they will come back to you and you'll find them regrowing, coming in all kinds of bizarre configurations.
It's possible that this may be that you're constantly fighting this disease. You may not be able to finish with this approach and have consider a cure, but maybe a stable, and it's hard to argue that we did something versus the natural history. I can see that. But I have to say that even the patient comes asymptomatic to you, you place them on aspirin, for example. Are you concerned about perforator strokes? Are you concerned about, so the disease is 3 components: mass effect, hemorrhagic, and ischemic. This disease, if we count only the anatomical aspect of it, you may not see changes over many years like you described, but I guarantee to you that they are having microstrokes here, a little bit of mass effect there, and it takes a long time for, the time they become symptomatic, I think it's just too late. That's what the disease is progressing. You may not be seeing that because it's just, luckily the perforator didn't cause a major event or something, but the disease is progressing.
And I agree 100% with what you're saying. I'm just saying, I feel like we are at an experimental stage. And the only patients that really justify the experiment are the people that have no hope.
I can see that, but the other thing though is that there's going to be very difficult for us to treat this disease with one device. Do you have an agreement on that? I don't think that there is one device that we're going to be able to fix this type of problem.
I would agree, like you may need a constellation of devices, but
Yeah. So I think
and each aneurysm may demand a different tool.
So if there's one thing I can ask you to consider in my talk is like, do you think that the stage vertebral artery, even in a symptomatic patient, makes any sense to you? Like they control the thrombosis of the aneurysm sac. So you're okay with the thrombosis of the how many times you had to take a posterior fossa of somebody to decompress the posterior fossa because of acute swelling of the aneurysm sac?
So we got into trouble because we didn't recognize that initially, and we got into issues with the hydrocephalus, like the case I showed. Now we know how to adjust to that, so we shunt them first, and then we do other things. You may need to do a decompressive craniectomy first before you go and you attack it. But I think that with this kind of disease, it's like hunting a lion. You don't wound the thing and let it come at you. You kill the thing. I think it's a flaw to think you can tease this somehow. I'm not saying that, because I lived through the days of sort of single vessel takedowns of the one vert. And people swore by that for a while. And they all came back and they all continued to grow. And so I'm very suspicious of staged therapies, unless it's staged over, I intend this thing to be cured in a month, and I'm going to do a couple of rapid procedures.
Yeah, I mean, we are talking about 2 to 3 months apart from those assessments, but I think this is far from, and this is part of the provocative issue. It's just that I want to basically to share with you that this is the best way I found to handle a problem that otherwise I'm trying to create some kind of consistency on some treatment that is so random, right? And we don't have that.
No, and I applaud. I mean, look, I'm watching what your results and the Buffalo results are going to be, because I'm curious. You might stumble on something that is the correct approach. But I get a little worried when we compare the asymptomatic to the morbidly symptomatic patient, because it's a different group. And you can fool yourself to think that you're doing something by a staged treatment in a minimally symptomatic patient.
I think
is all I'm saying.
I understand.
So, do you do now routinely the prophylactic decompression, posterior decompression in the asymptomatic patients?
Not routinely, but I think that is a consideration when you have a very large aneurysm. You really think about that. You get that, because inevitably that's what I see myself, and then I'm doing that surgery with aspirin, Plavix, and all kinds of things. It's a mess, and even a shunt, upward herniation, all kinds of things can happen. These people, when you get to that, you're too late, honestly. I don't feel that that's a good, you're really trying to just correct damage, and you're never going to catch up again. If you are proactive on this, I think would be smarter to do.
So the reason we start closing the other word is just because we saw results that, the pipeline is closed, but the aneurysm is filling from the other word that we don't close. So what is your timing, because you got to close in some time. Like after the first stage, you close like 2 months later, 3 months later?
It was symptoms on that patient. So the moment, if they get better after the initial treatment, I watch them. But if they become symptomatic, then I close the vertebral artery. You just treat the second one when the aneurysm sac basically is not responding. It's not thrombosing the way you would want it to. But I think the point is that if you close in the first day, I think you take too much of a hit, because the clot inside of the aneurysm sac you cannot control. That will go beyond the perforators, will clot everything out, and I think that's the big problem we have.
Thank you, doctors. It's time for coffee break. One question more.
One last question. Coming from a different background, I'm not an interventionalist, but has anybody looked retrospectively at the natural history of these aneurysms? That's the most important question in my mind.
Yes, so we published, we had an article a year ago, and there was also an experience at Mayo Clinic looking at long-term natural history of these. And mostly they, I don't know what it is, maybe a 4 or 5% annual rupture risk, but it's not absurd. It's not it was 3.7 annualized rupture risk. Most of them die from other causes, either the ischemic reasons, and 2/3 of them die of peripheral cardiovascular reasons.
Are these location specified, meaning tip of the bacillar, mid-bacillar?
That's where, I think we're kind of at the beginning of
we all know
we need to separate all of these aneurysms. There are different cohorts, and some of them are amenable to treatment and some are not. You can have very impressive cases, like the one that I'll show you, which was the very first one we did the pipeline. We go, wow, this is amazing. But it's a segment of the basilar that isn't addressable.
Right. The question is that if you know the natural history and if you know that the progression of the disease is such, I'm just sort of reminded about the unruptured aneurysmal history and how people used to put coils in stents, and I've seen people put coils in ophthalmic arteries, 2 millimeter ophthalmic artery aneurysms, and blow them up. So there's always this risk of not knowing the natural history and tending to progress,
This is not the case here. I think the point of this discussion and the point of this whole session, I think, is because we know too much about the natural history is probably what we know the most. In terms of what we don't know is to differentiate when this disease will become malignant versus is something that we can follow. That is one issue that it's not that we don't know about the natural history, is maybe we don't have enough markers to dictate, when it may be even that it's something that an event in patient's life that triggers the progression of the disease. Those things we don't know. But I think what Kim said, I have to say most of these patients do have aortic aneurysms, coronary disease, peripheral vascular. So perhaps that would be one marker, is not only look at the head, but look at how the disease is progressing everywhere else in the body. That's room to work there. Meanwhile, though, these patients are showing up in your office, so we need to have some kind of approach to it. My talk is mainly to say that this is not like every day you come in, you give a different treatment. I think what we need to start doing is that isolate this disease as a particular problem, fusiform vertebrobasilar aneurysm, and then we start consistently have an approach to it. We learn from that approach, and then we'll move on to another way. But the way it is today, you probably saw today 5 or 6 different ways to do this. And it's very difficult to learn much. So what we decided to do in our place is that we consistently follow this approach of stage. We do a hybrid construct, and we'll see where that takes us. If it may be that next year I'll talk about we totally, this is not working for us. We had all recurrences or this and this. So far, it's been okay, So.
Are all these patients treated with the best medical management before you start to do it?
So again, if they have a hemorrhage, there's no medical management for that, right?
Ischemic events.
But listen, the ischemic events is probably, it's a devastating part of it, but mass effect and hemorrhagic are surgical problems, right? So I think the issue here is this disease has 3 ways to get you, and most of the time, what we're talking about here, you exerted, what is the medical management? Are you going to treat blood pressure, cholesterol, and this will take you so much, but it's not going to stop the progress of this disease.
How do we know that? That's the question. Because we used to believe that. And being a stroke neurologist, I can tell you that, you know the data as well, that carotid artery disease treated maximally with best medical management.
I've seen this in 8-9-year-old. This problem happens it's honestly maybe not the same disease. One is atherosclerotic, the other one. But the point is that anatomically, if we qualify as vertebrobasilar disease, it will happen in different forms and shapes.
Correct. But all I'm saying is that the rate of CAs have gone down tremendously because of aggressive management. So the point is that history is not known. And so there needs to be some sort of a trial or some sort of observational, study to show.
I think these
what is the
patients,
difference.
because of a staged approach, we're seeing them in the office much more often than before, which is probably a big mistake we used to do, is you treat it and send them out. We see these people regularly, and maybe we are going to have an impact in the end, not in the disease in the brain, but because we're managing them better medically. That's very possible because we're seeing them more often. That may be because many of them will die of a heart attack or something else.
Maybe you have this experience too. I find that actually these patients are fairly intensively medically managed because they all have a cardiologist. They're all seeing a neurologist. They're on all kinds of medications to control their atherosclerosis. And so I don't think it's the lack of medical management on most of these people, so they're usually fairly intensively covered. And I agree, look, there's a psychology too, because even when they're minimally symptomatic, when they find out they have a disease like this, the fear in the physician's face is enough to scare them. But, it's an interesting dilemma, and I guess we'll see how it plays out in your next year.
After a coffee break, Dr.